Today we'll be talking about the diagnosis and management of food protein-induced enterocolitis syndrome, also known as FPIES. Here's a slide of my disclosures, which should not have any impact on the lecture today. And this is a brief outline of what we'll be talking about. We'll first discuss briefly a survey of pediatricians about FPIES. We'll go over a clinical vignette, introduce the audience to FPIES, then touch on some epidemiology and pathogenesis as well as food triggers and clinical features. We'll go through a second clinical vignette and pick up where we left off on clinical features, then diagnosis, initial management, natural history, and follow-up of FPIES, as well as some summary and final thoughts. So first, the survey of pediatricians about FPIES. This was a survey from the Quad AI a few years back. And of the 86 surveys completed, 20% of respondents of the survey demonstrated that they had a full understanding of FPIES. Just over half stated that they had a limited understanding of FPIES, and about a quarter stated that they never heard of FPIES. Of the respondents, 40% reported managing FPIES by themselves, about referred out to a gastroenterologist, and 35%, approximately 35%, to a pathologist. This survey of pediatricians really underscores that there's really limited knowledge about FPIES in the community and just generally amongst pediatricians. And there's clearly a need for education and establishing a role of allergist in the diagnosis and management of FPIES. And this is an observation from this survey, but also from my practice, where often parents come to the clinic after having learned about FPIES on the internet. And these patients are often misdiagnosed, and there's often a delay in diagnosis. So let's jump into the clinical vignette, the first clinical vignette. This is a 20-week-old former full-term infant who was exclusively breastfed and was beginning to introduce, the parents were beginning to introduce solids in their diet, into the child's diet. And first, as we normally would do, started introducing rice cereal, which the child tolerated. And then at 17 weeks, a few bites of apple were introduced. And then at 18 weeks, a larger amount of rice cereal and apples were introduced. With the first few ingestions, the first ingestion of rice cereal and apple, this child just did fine. But with larger amounts at 18 weeks, about 2 hours after ingestion, this child had recurrent non-bilious emesis and dry heaving. Was brought to the emergency room, but looked well by the time of arrival and eventually diagnosed with gastroenteritis and sent home. The infant recovered and in the next few days did pretty well exclusively breastfed, and the parent decided to give some solids again and introduce that again and see how they did. Gave rice cereal again at that moment, and about an hour and a half later developed emesis, and again repetitive non-bilious emesis. Was taken to the ER where the infant was limp and ill-appearing, afebrile, and was treated with subcutaneous epinephrine without improvement and IV fluids. Eventually was admitted and given IV fluids and gradually improved over a few hour period. Of course, due to the patient's age, they had a sepsis workup which was negative, and this infant was eventually determined to have FPIES, which is a non-IgE mediated gastrointestinal food hypersensitivity. The typical manifestation of FPIES is often delayed. In the acute setting is delayed and can lead to dehydration, lethargy, and possibly shock. Or in the chronic form, one can have weight loss and failure to thrive over time. This primarily affects infants. Cow's milk and soy are the most common culprits, although other foods can be triggers. And it does have characteristics that overlap with other non-IgE mediated GI disorders. We're not going to go over every aspect of this table here, but this is just to underscore the fact that FPIES is under the umbrella here of infant gastrointestinal disorders, which is essentially a non-IgE mediated process. The diagnosis of FPIES is based on clinical symptoms, and typically clinical symptoms with improvement following the withdrawal of that causative food. As mentioned earlier, it's often misdiagnosed. Viral gastroenteritis or sepsis can be a diagnosis made, but it's often those are often misdiagnoses when a child has FPIES. In some cases, an oral food challenge is performed to confirm the diagnosis, but not always, and it's not always necessary, as we will discuss. Treatment is essentially elimination of that trigger food. This is a relatively busy table, but again, to demonstrate the non-IgE mediated infant GI disorders. And FPIES really represents a more severe form of all three of these. There's FPIES here on the left-hand side. In the middle is food protein-induced proctocolitis, and on the right is food protein-induced enteropathy. There's just some discussion as to whether FPIES might essentially be, in chronic form, might be a food protein-induced enteropathy. But in general, FPIES would be determined as being very rare, versus something like food protein-induced proctocolitis here in the middle is quite common. This is often, the culprits are often milk and soy protein, often protein in breastfed infants. These are otherwise very healthy infants who just have streaks of blood or bloody stools early on when nursing. And they end up doing quite well when the nursing mother, avoids milk and soy in their diet, and it often resolves by 12 months of age. On the other hand, food protein-induced enteropathy, which is quite rare, it really presents as malabsorption, failure to thrive, anemia, diarrhea, vomiting in some cases, generally resolves by 2 years of age. And this is something that gastroenterologists often see and often diagnose, largely due to the fact that when these patients are also biopsied, you do see some patchy villus atrophy. So it is consistent with its name, which is an enteropathy. We'll be talking more about FPIES in general as far as the clinical symptoms. But first, we'll talk about the epidemiology and pathogenesis of FPIES. There's really no prevalent studies of FPIES from populations other than Israel. There is a slight male predilection. Reports of FPIES in siblings of the affected children have been reported, but quite rarely. And one of the largest studies looking at the epidemiology was from a large cohort in Israel looking at infants with allergy to milk, and found that about 0.34% of infants were diagnosed with FPIES. And the question was, from this study was, is FPIES more common than previously thought? In the same cohort, the incidence of IgE-mediated milk allergy was 0.5%. In regard to pathogenesis, as we discussed, FPIES is a non-IgE-mediated allergy. So typically, when you do get blood work on these patients in regards to food-specific IgE or skin prick test them to foods, they're often negative in most cases. And the actual pathogenesis and underlying mechanisms are really understood, and I should say are not clearly understood, and there is some research going on to what the actual underlying etiology is. But the thought is that it's a T-cell mediated process, inflammation and increased intestinal permeability and fluid shift. However, in a study quite a while ago, probably in the 1980s, demonstrated that intestinal absorption was actually normal in a group of infants with FPIES, confirmed by oral food challenge. One study from 2004 was looking at IgA and IgG4 levels and found a decrease in serum's food-specific IgG4 antibody and increased in serum's IgA levels, food-specific IgA levels, namely. In 2014, another study found that both casein-specific IgG4 and casein-specific IgA antibodies were significantly decreased in milk-induced FPIES. Interesting, but it's difficult to know what the actual significance of these findings are. This was a relatively interesting study by Chung and colleagues looking at the intestinal mucosa of infants with FPIES, and found that there was increased TNF-alpha and decreased expression of TGF-beta receptors in the intestinal mucosa. TGF-beta can be protective, so if it was decreased expression, there could be some role there with this imbalance of TGF-beta and TNF-alpha. So the epidemiology and pathogenesis, there still clearly needs to be more research done on FPIES to elaborate on that. In regard to food triggers, milk and soy we discussed can be the most common food triggers in FPIES. However, solid foods can also play a clear role. And of the solid foods, rice is the most common solid food implicated in FPIES and is responsible for nearly half of FPIES episodes requiring hospitalization. For some reason, rice tends to be quite severe in regard to the reactions seen in these FPIES patients. Here on the left, you'll see not only grains, but also meat and poultry and egg and vegetables and fruit and legumes and seafood, as well as probiotics have all been described. In regard to grains, if there's a history of FPIES to one grain, then about 50%, you can have a 50% risk of FPIES to other grains. Interestingly, though, wheat has not been reported in infants with oat or rice FPIES. Egg is generally a less frequent trigger of FPIES, but has been described in certain patient cohorts. This is just a table here, or graph, really showing that milk and soy are clearly the most common causes of FPIES, followed by rice and oat. What about FPIES in exclusively breastfed infants? And this has occurred, but really quite rare. It's thought that there is a protective role of breastfeeding in FPIES, possibly, and could it be that there's the presence of TGF-beta, which can be protective in the gut, and the presence of IgA in the mother's milk. There have been a handful of cases of FPIES to cow's milk in exclusively breastfed infants. Goat's milk has been reported in an Italian series, not completely surprising, as mammalian milk can be highly cross-reactive. As far as the clinical features and age of onset, when it comes to classic FPIES to milk and soy, the symptoms usually begin in early infancy, and in rare cases can begin in the first days of life. As far as solid food FPIES, it's typically later than that of cow's milk or soy FPIES, and usually presents when these foods are introduced around 4 to 7 months of age. What about FPIES in older children and adults? And this has been described mainly to things like shellfish, fish, and often egg has been described in this population. And the clinical symptoms are fairly similar. It's a non-IgE mediated GI hypersensitivity, where a patient will have shrimp, for example, and have protracted emesis more than an hour half or 2 hours after ingestion of the causative protein. As mentioned earlier, FPIES can have two phases. One can be chronic, where you can have an initial presentation of cow's milk or soy-induced FPIES, where the food is actually ingested regularly, and so you'll have more subtle symptoms, such as loose stools, poor growth over time. But this chronic phase can be followed by an acute phase, which is more of a robust reaction, often seen as discussed in that first case presentation as protracted emesis about an hour and a half to 2 hours after ingestion. Acute presentations can also be seen when the antigen is ingested intermittently. And in regards to the chronic presentation, it's usually those patients who have FPIES to cow's milk or soy, and solid food FPIES can both have an acute or a chronic presentation depending upon how often that food is ingested. This is a table just comparing some of the symptoms of chronic versus acute presentation. In regards to chronic FPIES, it really is an ill-defined condition, and many times is a diagnosis of exclusion. If patients present in this way, they clearly need to be seen by a gastroenterologist. In the acute presentation, sometimes the food it's very clear that it was one specific food that caused these symptoms, and the patient's symptoms are essentially absent when that food is not being ingested, such as something like rice. This second clinical vignette really walks us through the description of chronic versus acute FPIES. And this is a full-term female, initially exclusively breastfed, started on cow's milk-based formula supplementation about 6 weeks of age. The infant developed episodes of poor weight gain and intermittent vomiting and spitting up, as well as frequent loose stools, over a 2-week period of daily formula intake. Due to those symptoms, the patient was switched back to exclusive breastfeeding until another feeding with cow's milk-based formula at about 12 weeks of age. And 1.5 to 2 hours after this feeding, patient developed repetitive vomiting. And this would be described as an acute FPIES episode. The patient was eventually taken to the ER where a full workup was done and was reassuring, but due to the patient's age was admitted and observed for a few days while receiving IV fluids and antibiotics. In the hospital, the infant was tolerating extensively hydrolyzed casein formula and was discharged when all the cultures were negative. And this infant was avoiding cow's milk strictly and was tolerating various solid foods introduced at 4 to 7 months of age without any symptoms until they accidentally had a jar food containing some dairy. And similar to that previous episode, had symptoms of acute FPIES. So getting back to the clinical features, can one see atopy in FPIES? We mentioned a few times now that FPIES is a non-IgE mediated process, but there have been episodes, or I should say many cases described where IgE is present to that trigger food, and up to 25% of infants and children fulfilling the clinical symptoms of FPIES have developed, or actually has at the time, IgE to that trigger food. And patients with atypical FPIES tend to have a more protracted course and a potential for developing symptoms of IgE-mediated allergy down the road. And from the data from Mount Sinai, about 7 of 17 children with milk-induced FPIES who developed milk IgE positivity actually progressed to immediate allergic reactions. And these immediate allergic reactions range from mild symptoms to anaphylaxis. And about 40% of the children with FPIES had concurrent demonstration of IgE or food-specific IgE to other foods in that patient population. And it's clearly been demonstrated that atopic disease can be associated with FPIES. About 25 to 65% can have atopic derm and also asthma and allergic rhinitis. There is a family history of atopy in a good percentage of FPIES patients, depending on what study you look. That can range from 40 to 80% of patients, as well as a family history of food allergy in about 20% of those patients. As far as laboratory and radiographic findings, we won't go through every single one of these, but we should make note that most of these labs are not obtained and not necessary for the initial diagnosis or initial evaluation of FPIES. A lot of them have been obtained because the diagnosis was in question. So if one has a clear clinical history consistent with FPIES, uh, this sort of laboratory or radiologic evaluation is not necessary. However, if a patient presents, particularly in the chronic form of FPIES, I believe that labs and at the very least a gastroenterology evaluation would be necessary in the chronic form. And a lot of these findings, particularly the radiographic findings, can be nonspecific. So if there can be a subset of patients with FPIES who have atopy, what is the role of allergy testing? By and large, as we mentioned earlier, these patients have negative skin tests and negative food-specific IgE, and the exception was the atypical FPIES, as we recently mentioned. In regard to atopy patch testing, we had earlier mentioned that the pathogenesis of FPIES is thought to be a T-cell mediated process. So one would think that patch testing may be of benefit. And in order to look into this, a group from CHOP at the Children's Hospital of Philadelphia looked at patch testing and evaluated 19 infants with challenge-confirmed FPIES and found that atopy patch testing correctly predicted a majority of the outcomes of the oral food challenges. However, the same group in 2013 did a retrospective chart review and found that looking over 450 of their FPIES cases, that skin testing and atopy patch testing were not helpful at all in identifying trigger foods. And patch testing is no longer done at that institution as far as I am aware of. And we typically don't do any sort of atopy patch testing any longer for the diagnosis of FPIES. That said, further evaluation would be useful to determine whether, if at all, there is a role of the atopy patch test in FPIES. What about diagnosis? So clearly based on clinical history and the clinical symptoms, with clinical improvement following withdrawal of that causative protein. And in some cases, one needs to exclude other causes. If necessary, and is not always necessary, an oral food challenge can be done, but in the proper setting. And there are no laboratory or radiographic findings that are specific to FPIES. A CBC with differential could be useful in the acute presentation, where you'd see an elevated white cell count and left shift. A met hemoglobin level could be helpful as well and can be elevated in the very acute sweating, where the setting where the child may appear gray or cyanotic or very ill. Endoscopy or biopsy is generally not routinely performed, but might be necessary in severe or recalcitrant cases of FPIES. Despite the fact that skin tests and food-specific IgE are typically negative and expected to be negative, this is still done to confirm that it is negative. And if it is positive, then it might lead you to either other diagnoses such as IgE-mediated allergy or an atypical FPIES scenario. As mentioned in the first few slides, there's a clear delay in diagnosis of patients with FPIES. I think this is in part due to the lack of understanding of what FPIES is and that it exists. Its clinical presentation can mimic other disease processes. And a lot of these patients often undergo unnecessary and sometimes risky therapeutic interventions. And there is a delayed diagnosis, and that could be due to the fact that there is some perception that some of these foods introduced early on in life, such as rice or oats or vegetables, have a low allergenic potential and aren't typically suspected as triggers of food reactions. The gold standard for diagnosis of FPIES is the oral food challenge, and as mentioned, Many times it's not required. Um, However, if there is an unclear history and a specific food trigger has not been identified, an oral food challenge may clearly be necessary. Also, if there's an atypical time course of symptoms um, in the clinical history, that's where an oral food challenge could be necessary. And furthermore, the third reason to do an oral food challenge would be if the child has persistent symptoms on an allergy restricted diet and you want to find out what other foods are the trigger foods. This is a food challenge protocol from Up to Date. I listed it because it's a very complete protocol and is recommended for any patient to have these available to them, and goes down potential laboratory findings that can be seen in positive challenges, and as well as going through what the treatment for a positive challenge is. Here's a differential diagnosis that needs to be kept in mind when a patient presents with symptoms of FPIES. We won't again go through each one of these, but it ranges from allergic to non-allergic, specifically infectious, and there's other GI disorders to consider, as well as other things like metabolic disorders. The initial management of FPIES is eliminating that trigger food, and a casein hydrosylate based or hypoallergenic formula would be recommended in infants with cow's milk FPIES if breastfeeding is not possible. Um, in the rare case of FPIES in nursing infants, the mother should completely eliminate the trigger food from her diet. And if an infant has chronic symptoms, uh, they will improve if one switches to a casein hydrolysate based formula, but it can take about 3 to 10 days. Amino acid based formulas have been used in FPIES and has been necessary in about 15% of patients. This slide really helps in the initial management when you have a patient who maybe presents in early infancy with symptoms of FPIES. It's often a conundrum to know what foods to introduce in these children and how to introduce them. The general suggestions are the introduction of yellow fruits and vegetables at 6 months of age instead of cereals, with the thought that these can be often less likely to cause acute FPIES reactions. It's important to keep in mind that about a third of patients with cow's milk or soy FPIES, also known as classic FPIES, can develop solid food FPIES. At 12 months of age, it's suggested that we delay the introduction of grains, legumes, and poultry until this age, especially when they have solid food FPIES, largely because of the high rate of reactions to multiple foods. This is a tough thing, particularly with when we have information coming out about the LEAP study, where you can introduce peanut, for example, in these high-risk infants at 4 to 11 months of age. One has to wonder is, are we potentially inducing IgE-mediated reactions, or I should say, causing increased IgE-mediated sensitization in these patients? However, due to the way FPIES presents, these are the current suggested guidelines. However, nothing is really set in stone as of yet. Typically, we need to keep in mind that these recommendations are based on single center experience, and these recommendations and suggestions may clearly change as more data about FPIES emerges. And when it comes to these actual decisions of when to introduce these foods, I should underscore the fact that these are suggestions, and the discretion is really best left to the treating clinician, because there is a paucity of data with introduction of food in FPIES. When it comes to cow's milk or soy, this may be attempted after 12 months of age and preferably under supervision of a clinician if there is no prior history of reacting to these foods. it's important to keep in mind that if one tolerates a type of food from a high-risk group, such as soy for legumes, or chicken for poultry, or oat for grains, for example, this can increase the likelihood of tolerance to the other foods in the same group. What about baked goods? We know that when it comes to IgE-mediated food allergy to milk or egg, that eating baked goods may potentially help these patients uh, tolerate those foods earlier on than they otherwise would if they were not eating baked goods at all. However, when it comes to FPIES, with IgE-mediated, uh, in contrast, I should say, to IgE-mediated cow's milk allergy, baked goods with milk or egg, for example, has not really been studied well. And the concern is that when one bakes products, it doesn't necessarily alter those sequential epitopes that would continue to be recognized by T cells. Remember, FPIES is a T cell mediated process, so that baking milk, for example, in a cupcake may not actually um, alter those epitopes enough, and so the patient can clearly potentially react to that food. So currently, the general recommendations are that when it comes to FPIES, that those patients avoid all forms of cow's milk and dairy, including those products that have milk in it, even as a lower ingredient, especially even if it's a baked good. Every patient who has FPIES, it would be very prudent to send them home after evaluation, to send them home with an emergency treatment letter. And this treatment letter outlines the clinical features and management of acute FPIES. The reason being, as we mentioned earlier, a lot of these patients can present to the ER and are misdiagnosed, or even though the diagnosis is known, the treating physician may not know what FPIES is. And because it's a relatively rare diagnosis, and because we're learning more about FPIES and teaching our colleagues in the emergency room or general pediatric practices about FPIES, at least for the time being, it's important to have a treatment letter, which essentially is this. And this was developed by Scott Sitcher from Mount Sinai. And this essentially goes through what FPIES is, talks about how to potentially treat it, and allows that treating physician to use their own judgment to rule out certain things like FPIES or other acute gastroenterologic disease processes. As far as the emergency treatment plan for FPIES, there's really no studies to support any particular protocol. These patients should be taken to the emergency room, and IV fluids should be administered, particularly if the episode is severe. There has been some um, thought about using methylprednisolone and supportive therapy, such as vasopressors, to maintain blood pressure. The rationale behind glucocorticoids is the fact that this is a T cell mediated process and may be helpful. However, there's really no data to confirm the efficacy of glucocorticoids in the acute setting. Epinephrine has been used in patients with shock, but in FPIES, anecdotally, has not shown to be helpful. However, one would not fault a physician for trying that in the acute setting, in addition to what was mentioned above. Ondansetron or Zofran has been promising, and a small case series shows that it can be potentially helpful for acute FPIES symptoms. Now, this study was done in a hospital setting, not necessarily in an outpatient practice. Or I should say, not only in an outpatient setting, but also at home. So there's no, and I don't think it would be indicated to potentially prescribe this to parents for them to give it to their patient or their child orally, for example. This was done in a supervised setting and was quite effective in treating emesis and abdominal pain. Now, when it comes to home treatment, If patients have very mild reactions, for example, one episode of vomiting or maybe two episodes of vomiting, but otherwise look very well, they can be rehydrated at home carefully. Of course, the exceptions being those patients who have had very severe FPIES reactions in the past, those patients should be taken to the emergency room immediately. What about the natural history and follow-up of FPIES? Well, as far as the natural history goes, cow's milk and soy FPIES resolves in the majority of patients by 3 years of age. Solid food FPIES and atypical FPIES may have a more protracted course. And oral food challenges are used to determine if FPIES has resolved. And this is a conundrum as far as when to challenge these kids. And I think it really depends on what data you're looking at. When you're looking at certain data, for example, from Mount Sinai, the median age of resolution of cow's milk induced FPIES was about 14 years of age in this cohort of 160 patients, with a median age of resolution of 5 years with those with undetectable milk IgE. By contrast, when it comes to cow's milk and soy FPIES, you looked in the Italian series, which had a mean age of resolution about 2 years of age. The Korean cohort, over 60% resolved by 10 months of age, quite impressive. And in the Israeli cohort, about 90% resolution by 3 years. And these differences, geographic differences that we see between different patient populations, could be explained by the higher proportion of subjects who had a detectable food-specific IgE and atopic derm in the Mount Sinai group versus those from the Israeli and Korean studies. When it comes to soy specifically, again, the Korean cohort had a resolution quite early by 10 months. A cohort from Australia had 83% of soy FPIES resolving by 3 years of age. And in Mount Sinai, about a quarter of soy FPIES resolved by age 3 years. Solid food FPIES from Mount Sinai, resolution by age 3 years occurred in about 67% for vegetables, 66% for oat, and 40% for rice. In Australia, resolution by age 3 years occurred in 80% for rice, and in Italian series, mean age of resolution for solid foods and soy was about 53 months of age. And an oral food challenge is used to determine whether FPIES has really resolved before the food is reintroduced in the diet. And so depending on what cohort you look at and what part of the world you look at, there are different recommendations. Mount Sinai recommends follow-up challenges every 18 to 24 months in patient without recent reactions. In Korea, they recommend follow-up challenges to be undertaken sooner, however, after 12 months for cow's milk and about 6 to 8 months of age for soy, which is quite early. And further studies really need to establish what the optimal time is for oral food challenges in these patients. A limiting factor here is that many of us, at least in outpatient practices, are reluctant to challenge these patients, and rightfully so. It's recommended, and in general, that when challenging these patients, that IV access be present. And personally, I would recommend challenging these patients in a setting such as a hospital setting with an IV in place. And follow-up evaluations. When we see these patients regularly or annually, testing for IgE prior to a food challenge would be the right thing to do, particularly to detect atypical FPIES. It's helpful to know if somebody has IgE sensitization, regardless of whether they presented as a classic FPIES patient. Skin testing is still necessary because that presence of IgE would really impact how you would perform the oral food challenge moving forward. So just some summary and final thoughts. FPIES is a non-IgE mediated food allergy, primarily presenting in infancy. The most common food triggers are cow's milk and soy formula. However, FPIES can also be caused by solid foods, most common of which is rice. The classic symptoms, as discussed, were protracted vomiting and often diarrhea about an hour and a half to 2 hours after ingestion. In the acute setting, there's a risk of dehydration and lethargy, or weight loss and failure to thrive in the chronic form. And again, there are no laboratory or radiographic findings that are specific to FPIES. The diagnosis is therefore based upon clinical history and clinical symptoms, with improvement following withdrawal of the causative food. The initial management is not only eliminating that offending food from the diet, but an emergency treatment plan is necessary and a letter for any future episodes or accidental exposures. Typically, depending on what data you're looking at and what cohort you're looking at, cow's milk and soy FPIES usually resolves by age 3 years of age. Solid food FPIES and atypical FPIES can have a more protracted course. And pediatricians, as we know, have a limited knowledge of manifestations and management of FPIES, and to no fault of theirs. It's a disease process that we're learning more about, and we as allergists need to have a solid grasp for what FPIES is, and how to diagnose it, as well as educating our general pediatric colleagues. There's often a delay in the diagnosis of FPIES for many reasons, and a need for education about FPIES, as well as establishing the role of allergists in its diagnosis and management. These are two great resources for FPIES. One is the FPIES Foundation, and the other is the International FPIES Association.